to welcome you all to today's webinar in collaboration with AMOX. Today we will be discussing some critical topics affecting women's health, including premenstrual syndrome, menstrual cycle irregularities, and benign breast disorders. Today we are fortunate to have with us two highly renowned experts, Dr. Amaya Purandare and Dr. Rucha Kaushik, who will be sharing their valuable insights on the role of each of these conditions and the role of nutraceuticals in managing each of these conditions. So let me begin by introducing our first speaker, Dr. Amaya Purandare. So Dr. Amaya Purandare is a consultant obs and gynecs associated with Purandare Hospital, KG Somaya Medical College, and Sir H.N. Reliance Foundation. He is currently the Senior Vice President of AMOX and has held various positions in FOXY as a Joint Secretary, you can see, and as a Chairperson of the Food, Drugs, Medical, Surgical Equipment Committee. He has won numerous awards, including FOXY Young Scientist Award and the Pride of FOXY Award. The numerous awards won by Dr. Amaya Purandare shows his commitment towards empowering the women's health. So over to you, sir.
Thank you, Ankit, for Vivek, for those kind words. I'm indeed grateful to AMOGS and UNS for giving me this opportunity to be speaking on a very important topic related to women's health. I hope my...
Yes, sir. Yes, I tried us to do that.
Yeah, I hope that you can hear me and see me clearly, Vikas.
Yes.
Okay, so I'm going to be talking about menstrual health issues, namely PMS and irregular cycles, what the challenges women face, and how we can find solutions which are safe and successful. So, many thanks to the medical team of UNS NutriScience for the academic support in compilation of this presentation. As Nikki Tajiri said, all females deserve menstrual well-being, and that includes the knowledge and the reassurance about her body from the earliest possible age. It's not just menstrual hygiene, but it's menstrual well-being as an overall state that we need to be concentrating about. The first topic that I'm going to be touching is that of PMS. If you ask a woman who genuinely suffers from PMS, she has the following sentiments to say. She says, I'm having one of those days where even sounds and people's faces and simply just being awake annoys me. And therefore, it is definitely a extremely unpleasant and undesirable few days that the woman goes through. Scientifically speaking, PMS is a cyclical phenomenon characterized by a combination of somatic symptoms and psychological symptoms. These occur during the luteal phase of the menstrual cycle and disappear within a few days after the onset of menses. And therefore, it is rightly called as premenstrual or just before menses. It often begins in the 20s but can worsen between the years 30s to 40s. The severe form of PMS is now considered a psychological or a psychiatric issue, which is called as PMDD or premenstrual syndrome dysphoric disorder. 8 to 43% of women in one study have been reported to have PMS and PMDD respectively. So as much as 4 in 10 women do suffer from PMS. In this study carried out in Belagavi, Karnataka, among 420 college girls, found that as high as 86% of college-going girls have reported sometime or the other the symptoms of PMS. What are the symptoms of PMS? They are a wide variety and range from somatic problems like cramps and aches, psychological problems like irritability, depression, abdominal bloating, breast tenderness, anger, nausea, vomiting, fatigue, decreased concentration, mood swings, headache, anxiety, sleep disturbance, and appetite changes. As you can see, the presentation is diverse. But what we need to remember that each woman is having an individualistic severity. In what I mean by that is that the severity differs and not all women get all the symptoms. The RCOG has classified PMS into various groups depending upon the symptoms, the symptom free week, the influence on quality of life, the presence of severity during menstruation or menstrual irregularities, and additional factors. They range from mild physiological premenstrual disorder to the more severe problem, which is called as core premenstrual disorder or premenstrual dysphoric disorder. We need to remember that the day is very important as to when the severity of the problem occurs, because as I will tell you later, progesterone treatment can alter as the severity of PMS. So let us understand why PMS actually occurs. The short answer is that we don't know the exact cause, but several factors contribute to the condition. The most important being hormonal fluctuations during the menstrual cycle. These include an estrogen surplus and a progesterone deficiency. Estrogen levels fluctuate during the luteal phase, and the greater the fluctuation, the worse it is for the woman's mood. Women with PMS have also been shown to have high prolactin levels throughout the menstrual cycle. And prolactin interacts with ovarian hormones, causing low estrogen levels, which can lead to depressive symptoms, and low progesterone levels, which can lead to anxiety or irritability. The next important point is the mood hormone or serotonin, which is largely affected by the GABA in CNS. PMS is influenced by the action of progesterone on GABA and other neurotransmitters like serotonin and catecholamine, and also opioids. Therefore, pre-existing serotonin deficiency with increased progesterone sensitivity can cause PMS. Molecular studies have shown that decreased estrogen causes hypothalamus to release norepinephrine, which triggers a decline in acetylcholine, dopamine, and serotonin that causes insomnia, fatigue, depression, and these are common in patients of PMS and PMDD. In addition to that, the other causes include an abnormality in the glucose metabolism, the hypothalamico-pituitary adrenal axis, insulin resistance, electrolyte imbalances, and genetic factors. Another important etiological factor is increased prostaglandin, which can decrease many of the symptoms, trigger many of the symptoms of PMS. Dietary and lifestyle factors like smoking, alcohol, caffeine, less habitual exercise, poor sleep, fat-rich diet are also associated with PMS. One very important factor is stress. It amplifies sympathetic activity, and this results in the pain associated with menses being significantly greater in intensity of uterine contraction. How does PMS affect the woman? Well, it adversely affects the quality of life. It affects academic and professional performance. Daily living activities become troublesome. Occupation productivity reduces, and there is increased clinic visits to seek medical advice. Due to the high disease burden, the right diagnosis and management of the condition becomes crucial. Let us understand the diagnosis. The ACOG or the American College says that if the patient reports more than one of the following affective or somatic symptoms 5 days before the menses in each of the previous 3 cycles, the patient is suffering from PMS. The 3 elements which are confirmatory are symptoms being consistent. Symptoms should occur consistently only during the luteal phase, and they negatively should be impacting patient function and lifestyle. What is the management of premenstrual syndrome, therefore? Obviously, the wide variety of methods include, first of all, lifestyle changes like quitting smoking, diet change, meditation, and relaxation when the symptoms are mild. But if the symptoms are moderate to severe, medication may be needed, which can range from hormonal contraceptives those which contain low estrogen and are drosperinone based, antidepressants for relief of severe mental problems, painkillers for reducing inflammation, back pain, and production of prostaglandins, diuretics for swollen and sore breasts, and the use of gonadotropin releasing analogs in severe cases of PMS. And these should not be taken for longer than 6 months because they themselves can produce a menopausal like state and cause menopausal symptoms as well. But as you can see, all these treatment options have significant side effects. And if one has to take them over periods of time, these side effects can become worse and amplified. So therefore, the tire-based approach or the line-based approach for PMS can be simplified as first line, where exercise, CBT, and vitamin B6 combined with new generation pills cyclical or continuously, along with a low-dose SSRI like citalopram or escitalopram 10 mg, followed by a second line where estrogen patches with micronized progesterone or an LNG IUS, or higher doses of SSRI, or the third line where GnRH analogs with an add-back HRT therapy, and the fourth line, very rarely resorted, is surgical treatment with followed with or without HRT. A very important symptom associated with PMS is cyclical mastalgia. Now, cyclical, as the name says, is in definite relationship to the menstrual cycle, and therefore it's called as cyclical. Usually occurs in the luteal phase and resolves or decreases with the onset of menses. In 2/3 of cases, the mastalgia is cyclical, manifests about 30 years of age, usually bilateral and diffuse, but can rarely be unilateral or asymmetric, and often worse in the upper and outer breast quadrant and can radiate to the axillary region. Again, its etiology remains really undefined. Cyclical breast pain is strongly linked to hormonal fluctuations of the menstrual cycle. Increase in estrogen stimulates the ducts. Simultaneously, decrease in progesterone stimulates the stroma. Concurrent increase in prolactin causes increased ductal secretion, which contributes to pain and swelling. And there is also association of cyclical mastalgia with the use of hormonal therapy, with its resolution during pregnancy and lactation and menopause, telling us that when the hormones are imbalanced, this is more likely to be the cause and effect relationship, as and when the hormones are normalized, mastalgia doesn't occur. So we must find out the features in history to discriminate between the types of mastalgia. Cyclical begins before the onset of menses and improves after. Non-cyclical is not related to, and chest wall pain will be unilateral and brought about by activity. The cyclical pain is usually dull, heavy, or aching, while non-cyclical is constant or intermittent, and chest wall pain is usually very lateral or medial in the breast. Cyclical pain is usually bilateral, while non-cyclical could be variable and unilateral, and chest wall pain can be reproduced by pressure on a specific area of the chest wall. And cyclical mastalgia is usually poorly localized and extends to the axilla as well. Now let us look at the diagnostic algorithm. A patient presents with pain, you have to take a detailed history followed by a physical examination. It helps us to determine what the cause of pain is. In non-cyclical mastalgia, it is important to determine the exact underlying etiology for accurate treatment. So patient comes to you with pain, perform a breast examination, look for a mass. If the mass is palpated, refer her to a breast surgeon for further management. If there is no mass palpable, look whether the pain is focal or diffuse. If it is diffuse pain and the patient has risk factors or is 30 years or older, consider mammography. But if the patient does not have any risk factors, no imaging is indicated, provide reassurance. If the pain still persists, consider using NSAIDs or a well-fitted bra. If there is still persistent pain, think about danazol or tamoxifen. On the other hand, if there is focal pain and the patient is younger than 30 years, think of targeted USG. And if the patient is older, then think of targeted USG and a mammography as well. So, when the patient reveals a mass, work up for the mass. But if there is no mass, you begin with lifestyle advice, reassurance. If that still doesn't cause any change in the pain, and you think that it's a musculoskeletal pain, give her an NSAID. But if it's a breast pain, start off by giving oral or topical NSAIDs for 3 months. If there is poor response, give tamoxifen. If there is still poor response, think about danazol, and lastly, GnRH analogs. So this would be what the algorithm for management of mastalgia is. Again, to repeat, it's the same. But if you look at the various treatment options, tamoxifen is generally preferred, very well effective in 70 to 90%. Danazol is the only FDA-approved treatment option. Bromocriptine is known to prevent the release of prolactin, and goserelin is only for severe and refractory cases. So this is how the treatment option is. One must remember that these treatment options should be used only for short periods because they have significant side effects. So all of them have side effects. Do we have something where we do not have any side effects? At the same time, we have equal efficacy. And here we are thankful to UNS that they have come up with the power of two, that is the evening primrose oil and tocotrienol in PMS management, which is found to be very effective. So evening primrose oil, or EPO, is made from seeds of the evening primrose plant. It comprises of linolenic acid and gamma linolenic acid, as we call as GLA. The unique benefit of these compounds is that they have both anti-inflammatory and pain-relieving properties. How do they act? Like I told you, they act via the linolenic GLA pathway and have three basic mechanisms of action. One is anti-inflammatory via increasing of PGE1 levels and decreasing of the inflammatory markers via GLA, affecting the PGE1 synthesis and suppressing the effect of prolactin. And third is restoring the balance of GLA and its metabolites by which reduces the breast pain by being anti-inflammatory in nature. In addition to this, vitamin E has been known for its robust antioxidant properties and has showed a positive impact on PMS. B6 is also a factor in the final stages of serotonin dopamine synthesis, and many studies over the ages have suggested a beneficial effect of vitamin B6 on PMS symptoms. But we need to look at tocoretinol, which is vitamin E beyond the tocopherols. So vitamin E has 8 different structurally related compounds: alpha, beta, gamma, delta, tocopherol, and tocoretinol. Tocoretinols, why I am emphasizing on them, is because they are the most potent antioxidant, almost 40 to 60 times better in potency due to their better distribution in the cell membrane lipid layers. And thus, they have a better free radical scavenging ability compared to the tocopherols. And tocoretinols, therefore, are more efficacious than tocopherol in alleviating the symptoms of PMS. And hence, the US FDA has classified them as a generally recognized safe medicine. Now, let us look at the real-world study to see whether this combination is actually effective, and was carried out as the PRIME study, where about 500 patients received this combination in India in 100 plus doctors over 3 months. And they found that the change in PMSS score from the baseline improved by 61%, the pain score reduced by 75%, and the breast pain score also reduced by 82%. And hence, they went on to conclude that this unique combination of EPO, tocotrienol, and B6 administered for 3 months demonstrated a significant improvement in PMS symptoms and they recommended that should be considered as a treatment option for managing female patients with PMS. In this study, you can see that of the two groups, there was a marked improvement in the total premenstrual daily symptoms, that is on a day-to-day symptom, which was found to be more effective in the treatment of PMS. These are various studies which have been carried out, and as you can see, that not only is there an improvement in the biochemical levels of GLA and DGLA, but also there is improvement in the breast symptoms, in the abdominal symptoms, as well as the psychological and sleep related problems in these various studies where this combination has been used. So if there is pain and the history and physical examination is normal and the patient is having a normal mammogram, then you can use this combination for about 3 months, where it is found to be very useful. And this has also been recommended in the Shaw's textbook, in the Mansell and Webster's Design Disorders and Diseases of the Breast textbook, as well as the Schwartz textbook of breast surgery. And here you can see that it has been shown to affect the prostaglandins, are found to be safe, and have been shown to be having a high response rate, and is now recommended as one of the first line treatments for cyclical mastalgia. Let me move on to a very recent study. And here, the uniqueness of this study was that it had various groups of various combinations. And you can see that the combination group of EPO plus vitamin D had the greatest superiority in terms of efficacy as compared to individual treatments in alleviating breast pain associated with cyclical mastalgia. Here you can see evening primrose oil and vitamin D significantly reduced the depression, anxiety, and stress, even greater than those patients who required who were given tamoxifen and danazol. Almost 90% of patients reported a complete resolution only with this unique combination, proving to be an efficient method for treatment of mastalgia. So to summarize, this combination is a natural, safe, and effective solution to manage PMS and cyclical mastalgia. But one must remember that a woman on an average spends about 3,500 days of her life menstruating. And therefore, understanding the menstrual cycle is the missing key in the well-being and creative output of women, as said by Claire Baker. What we therefore need to remember that there are times when the cycle is going to be erratic, it is going to be irregular, but we need to understand why this is occurring and whether it is associated with any pathology. Most often, when women come to us with menstrual cycle irregularity, they stress that, doctor, please give us some medication which is non-hormonal and therefore does not have any side effects. So what really causes irregular menstruation? In this study, which was a community-based survey, 1/10 of the women reported menstrual problems. And these problems ranged from painful periods, irregular periods, frequent periods, heavy periods, scanty periods, excessive periods, and intermenstrual bleeding as well. And therefore, scientifically speaking, we call this entire spectrum of menstrual irregularities or menstrual cycle disturbances as abnormal uterine bleeding or AUB. FIGO has classified AUB in two broad groups. One is based on the symptoms, and the second is based on etiology, which is called as the Palm-Cohen classification. On symptoms, it ranges from frequency, duration, regularity, volume, cyclicity, and unscheduledness of bleeding. And it ranges from terms such as polymenorrhea, oligomenorrhea, amenorrhea, which could be primary or secondary, duration problems like metrorrhagia, flow problems like menorrhagia or hypomenorrhea, But what we now look at as clinicians is the PALM-COIN classification, where PALM stands for structural issues like polyp, adenomyosis, fibroid, malignancy, or hyperplasia, and COIN stands for non-structural issues like coagulopathy, ovulatory dysfunction, endometrial issues, iatrogenic, and non-classified. I'm going to be talking about basically the hormonal disruption which occurs because of the disruption of HPO axis, which could be an ovulatory problem. It causes hormonal imbalance, and this leads to an irregular menstruation and a long menstrual cycle in women with reproductive age. Of course, irregular periods affect the quality of life, work productivity, and academic performance in young girls. But the long term problem includes infertility, in chronic anovulation, osteoporosis because of hypoestrogenemia, diabetes because of altered insulin resistance, cardiovascular disease associated with metabolic syndrome or syndrome X, and mental health problems as well. And hence, early diagnosis and management of menstrual irregularities can help reduce occurrence of rates of infertility and the sequelae of serious diseases like heart diseases and osteoporosis. How does one go about? So again, history is very important. One must look in detail at the menstrual history, the sexual history, the family history, the medical history, the medications history, and the social history and associated conditions. BP, weight, very important. Sign of pallor indicates heavy periods. Signs of endocrine disorders like thyroid issues or PCOS. Signs of coagulopathy, which can be seen especially in adolescents because of various congenital problems or deficiencies of factors, abdominal examination to rule out pelvic or abdominal masses, and a speculum examination to rule out any kind of malignancy or any kind of local issues like infection. Lab tests include obviously a pregnancy test, complete blood count, ferritin level, coagulation panel, thyroid test, prolactins, and other hormones as and when required. Imaging studies, very important, is ultrasound, MRI, and hysteroscopy. And endometrial tissue sampling may be required in patients of AUB who are at high risk for hyperplasia or malignancy. And in fact, in elderly women, a biopsy must be considered, especially in those who are perimenopausal or postmenopausal. The treatment will depend obviously on etiology and has to be individualized depending upon her desire for future fertility, her clinical stability, and other medical comorbidities. The goal can be broadly divided depending upon the cause, and therefore, if there is hyperprolactinemia, cabergoline would be the treatment of choice. Hypothyroidism, thyroid supplementation with levothyroxine, and surgical options for structural issues like fibroid, etc. Hormonal therapy remains the preferred initial line of therapy in those patients who do not have a structural issue. And hormonal therapy is generally OCPs, but OCPs can cause their own problems like breast tenderness, bloating, weight gain, migraine, increased blood sugars, more so life-threatening problems like thromboembolism and abnormal bleeding. Two main concerns are also for long term is the decrease in bone density and the fear of venous thromboembolism. And hence, counseling should be done for problems like weight gain, breakthrough bleeding, nausea, breast tenderness, mood changes, etc. With cabergoline, the common problems are related to postural hypotension, therefore dizziness, vertigo, headache, etc. Cardiac valvulopathy has also been seen in some patients, and others include increased lipido and behavioral changes and psychiatric problems. Hence, we need to look at a therapy again with a better safety profile in patients of irregular menses. And many of the patients today are aware and they say, doctor, please avoid any hormonal therapy because they have a myth that hormones are associated with cancer or with diabetes or with life-threatening thromboembolism. We have a newer treatment option which is now available. It's called as Vitex agnus castus, or the short form is VAC. It's nothing but chasteberry. Its active constituents include flavonoids, alkaloids, essential oils, and glycosides. And is a hypothalamic-pituitary ovarian axis regulator. It regulates the cycles, relieves complaints and complications stemming from dysregulation, and is commonly used in Europe and the English-speaking world for the treatment of irregular menstruation. And the German Commission has approved of its use for irregular menstrual cycle. How does it act? It acts basically via two main mechanisms. One is increases progesterone synthesis, thereby shifting the estrogen-progesterone balance in favor of progesterone and eliminates the hyperestrogenism, and it normalizes the estrogen-progesterone level. On the other hand, it acts as a dopamine agonist and reduces prolactin synthesis and hence improves the hormonal balance and regularizes the menstrual cycle by correcting the HPO axis. These are the various journal extracts which tell us that it acts via these two mechanisms and thereby normalizes the ratio of estrogen to progesterone and also reduces prostaglandin levels. It acts via the inhibition of FSH, it acts via the inhibition or the stimulation of LH and the inhibition of the prolactin releasing factor. Now, do we have clinical evidence for VSE in actual studies? In this large study of 1,700 patients, which took this medication as a BD dose for 3 months, they found that the 3-month therapy showed a pronounced improvement in key disease symptoms and quality of life. What they saw that it helped in patients with irregular cycles, in patients of breast tenderness, marked improvement. It almost corrected these problems. It also improved the bleeding intensity, frequency, and menstrual pain, enhanced the quality of life, and overall was well tolerated with a favorable safety profile. And in fact, they went on to say that it's correcting every part of hormone imbalance related symptomatology. In this study, which was published in the Planta Medica for 3 cycles in about 200 patients, they found that specific menstrual problems like polymenorrhea, oligomenorrhea, and amenorrhea were ameliorated significantly, and this medication was well tolerated. In this study, which is a recent study, which showed that by taking this medication as compared to bromocriptine in patients with prolactin, the hyperprolactinemia, it lowered the prolactin levels similar to bromocriptine and had better patient compliance. In this review article, which has been published in 2018, it showed that in these patients from Germany, where it was used as a homeopathic preparation, it found positive results with respect to increase in the luteal phase progesterone, improvement of ovulation, and was found to be useful in menstrual related issues. In this study from Iran in 2016, it was a randomized triple blinded clinical study. They found that luteal dysfunction was corrected by this problem in patients of PCOS and also showed a correction in the excessive androgen levels with respect to decrease in free testosterone and DHES levels. So not only is it clinically useful, but this study showed that biochemical correction was also present. In this particular book on toxicology and clinical pharmacology, they have gone on to say that it increases the luteal phase progesterone synthesis. And this is, again, the problem that I talked about as one of the key etiological reasons why PMS and irregular menstruation occurs. In this recent study, again from Italy, they went on to say that this medication is potentially useful and is a safe phytotherapeutic option for the management of selected patients with mild hyperprolactinemia who want to be treated with phytotherapy. But what we need to understand is that what is the correct dosage, what is the safety profile, and the precautions. So about 30 to 40 mg of the dried fruit should be consumed daily as a safe dose and an effective dose. It is safe and well tolerated. Mild symptoms are side effects may be present in less than 2%, but these are reversible and infrequent. And there is no herb drug reaction. Also, with oral contraceptives, may interfere with dopamine agonists, and therefore concomitant use of this medication with patients on dopamine agonists or antagonists should be used with caution or avoided, and it should not be used in pregnancy and lactation. Once again, UNS has over the years established its legacy with Primosa. We all, as clinicians, have found great confidence, belief in prescribing Primosa over the ages. But now they have evolved Primosa with these two unique molecules for treating the challenges that I talked about. Primosa Boost in PMS management, a combination of evening primrose oil and tocotrienols and B6 in a combination to be given as 1 to 2 soft gels for 3 to 6 months. And if there is menstrual irregularity, the preparation adds VAC and is called rightfully Primosa V. Again, the dosage is 1 to 2 soft gels for 3 to 6 months. This menstrual day, I was at the Radio City in a podcast spreading awareness on menstrual hygiene, because the WHO has now instituted the World Menstrual Hygiene Day. But what we need to understand, it's not just hygiene, but the women have to have a period-friendly mindset. Because let us normalize talking about menstrual cycles, not just on social media, but we need to do it with each other, with our patients, so that we can raise women who are comfortable with their bodies. We need to start this early, we need to spread it wide, and we need to be sensitive and at the same time take menstrual problems and PMS in our stride, both as clinicians and as patients and clients. Thank you so much. Once again, AMOGS and UNS, I express my gratitude for this opportunity.
Thank you so much, sir, for this insightful presentation. It was truly privileged to hear your expertise on the management of PMS and how the combination of evening primrose oil and tocotrienol, referred to as the power of two, plays a significant role in managing the symptoms of PMS and menstruation. Further, your discussion on VAC as a non-hormonal treatment was particularly enlightening, shedding light on its efficacy and the non-hormonal approach, how it is playing the potential role in management of irregular menses. So once again, thank you, sir, for your wonderful presentation. So now I will move to the next speaker. Just give me a second, I will share my screen. So it's my pleasure to introduce our next speaker, that is Dr. Rucha Kaushik. So she is a consultant breast surgeon at PD Hinduja Hospital and Medical Research Center with more than 10 years of exclusive clinical and research experience in breast cancer field. Her area of expertise include breast cancer surgery, including procedures like breast reconstruction and oncoplasty. Her work at Tata Memorial Hospital, as well as her involvement in globally recognized randomized clinical trials that reshaped the metastatic breast cancer management and the various publications in the breast cancer management underscore her expertise and commitment to advancing the women's health. We are honored to have her share her insights today. Over to you, ma'am.
Yeah.
Are you able to share your screen, and I should do it?
Can you share? I'm trying, but
okay. Yeah, we'll just end.
Yeah. Thank you, Vikas. Thank you so much. Thank you, AMOGS and UNS, for giving this opportunity. And because that whatever you have shared about those kind words, but you can add that experience of 20 years and not 10 years.
Okay.
So for future, you can just correct it. So thank you so much. And I would like to congratulate Dr. Ameya for such a extensive, nice, precise, and very informative presentation. And whatever he has not covered about cyclic pain, that I will cover, and rest I think we are going to cover fibroadenomas and fibrocystic breast diseases. So can we go on next slide, please?
Yes.
Yeah, so mostly in as a breast surgeon, what if I see 10 patients, 9 out of them will have some benign breast condition, and 1 will be suspicious disease. So we routinely see patients between 15 to 50. Though the peak age is 30 to 50 as book mentions, but we routinely see age group from 15 to 50 with a benign breast problems. Most difficult thing for patient is that whenever they feel that there is something, whether it's a pain, whether it's a lumpy feel, the first thing comes in mind is breast cancer. And nowadays we are seeing that even young patients, because of so much literature and so much information available on the Google and social media, young girls, they are coming with the fear that I'm having pain and whether it is a cancer. So this I'm seeing the change in trend, because initially when patient used to come with breast pain or lumpy breast pain, they never used to ask this question, doctor, whether it is a cancer. They used to come out of concern. But nowadays young girls, because of so much information, the first thing they have in their mind that I want to rule out cancer and I want to get mammography done. That is again thanks to social media, because they feel that mammography is the only tool which can rule out whether we have cancer or not. And sometimes it is very sad to see that young women of 30-year, 25-year walking to clinic with mammogram, and that to very poor quality. Routinely, we don't do mammography for benign breast diseases, that we will cover in next slide. I will try to keep it more on a clinical, how we treat as a breast surgeon breast problem, and when patient needs to be referred to breast surgeon, at what stage, so that we don't miss out on anything. And I will share some of my experiences, because mostly all breast cases, they come to gynecologist and first, and then patient is referred after few investigations to breast surgeon. So as we know that benign breast diseases are proliferative and non-proliferative. So non-proliferative, where it is a simple cyst or any apocrine changes, where we don't need to do anything for those patients. Again, proliferative lesions, they are classified into proliferative lesion without atypia and with atypia. Again, without atypia, we usually see ductal hyperplasia, intraductal papilloma, sclerosing adenosis, and fibroadenomas. Except fibroadenomas, rest have some potential to develop into cancer in future, depending on the age of the patient, at which age patient is presenting. Proliferative lesion with atypia, always biopsy will show atypical ductal changes or atypical lobular changes, where again we need to decide, depending on your clinical index of suspicion and mammography or sonography finding, whether we need to address it surgically or we can do wait and watch policy. So as we have discussed, simple cysts which are non-proliferative, even if they show some apocrine metaplasia, sometimes patients, they come with FNSE. So I would like to tell this, that for simple cyst, we don't do FNSEs. FNSEs as such we are not doing to diagnose breast cancer or to rule out breast cancer, because negative FNAC cannot rule out cancer. So if the index of suspicion is very high at your end or at radiological end, patient should always undergo true cut biopsy and not the FNAC. Other proliferative lesions without urticaria and with urticaria, again, we need to decide in which patients we need to do biopsy and in which we can do observation policy. So if young patient is coming with painless classical presentation of fibroadenoma, I would not like to do any biopsy or any FNAC. If the lesion is less than 2 centimeter, we ideally tell them to observe and come for close follow-up like 6 monthly or 3 monthly, depending on the associated symptoms. If patient is having pain or it's a painless thing. If having pain, then we call them every 3 monthly. If there is no pain, we ask them to keep the track of the size. Other lesions which are proven on biopsy. So how do we decide that which lesions we are going to do biopsy? So if patient walks into my clinic and she is 45 with some suspicious lump, then definitely I will get mammography done. But if patient walks into clinic with maybe no fibroadenoma, but you feel that the margins are irregular, the first choice of investigation is ideally ultrasonography. On ultrasound, if my radiologist says that it looks suspicious, then only we do mammography, because mammography in younger age group is not always helpful because of breast density. So choice of investigation is very important depending on the age group. Above 40, above 50, yes, I agree that if there is an index of suspicion, one should get mammography done after clinical examination. But below 40, I would not recommend mammography without seeing ultrasonography findings. Can we have? Yeah. So mastalgia is completely covered by Dr. Purandare, so I would not like to talk about it. And about palpable breast lump, so palpable breast lump and nipple discharge. So depending on the age of the patient, if patient fits into 15 to 30 and clinically, if you feel this is classically painless mobile lump, which is small lump, not affecting her day-to-day quality of life, patient is not very anxious about it, and she is willing to come for follow-up, we usually don't do FNAC to prove that it is fibroadenoma. We do ultrasound, we measure the size, and we keep patient on regular follow-up. Yes, definitely. If it is associated with pain, then we need to tell them that if that pain is affecting or hampering your quality of life, definitely it will need excision in future. But all fibroadenomas, if they are proven on radiologically and clinically, usually biopsy or FNAC is not recommended. Yes, when age is more than 40, where you don't suspect fibroadenoma, but the symptoms or the clinical finding is suggestive of fibroadenoma, there is a possibility of phylloides tumor, which is more common after the age of 35. Definitely, we prove it on biopsy, whether it is phylloides or fibroadenoma, and treat accordingly. Because phylloides, we cannot keep on observing. Phylloides is a locally aggressive kind of benign tumor, and it may turn into malignant. You never know. So we need to prove that this is either phylloides or fibroadenoma. If it's phylloides, it needs wide local excision. Yeah. So mastalgia we can skip. Can you go back to previous slide? Yeah. So palpable lump, most common are cysts, which are again in perimenopausal and postmenopausal women. So classical presentation is that patient will complain कि ये 2 दिन पहले आया. So suddenly appearing any lesion 2 days, and if you feel that the margins are well defined, you can clinically assess that this is cyst or this is suspicious. But still, if it is a complex cyst and patient is perimenopausal or postmenopausal, we do biopsy, core biopsy of the wall to prove that this is only a complex cyst and there is nothing inside growing. Phylloides, we have spoken. Galactosyl, again, depending on the age of the patient, if she's lactating. Fat necrosis, again, a very rare entity where patient present as a very tender nodular lesions in the breast. And that's again a clinical diagnosis, as well as if you feel the index of suspicion that you cannot rule out what it is, then one can get biopsy done. Vascular lesions we don't see routinely. Yeah. So fibroadenomas and fibrocystic breast diseases we are commonly seeing, but nowadays in past 5 years, I am seeing equally inflammatory lesions, which is idiopathic granulomatous mastitis or tuberculous granulomatous mastitis. So a patient will typically present as a inflammatory lump in the breast with either history of fever or no fever, tenderness, and it's coming and going with antibiotic, past history of similar lesion happening in the breast, and which was subsided with antibiotic. So again, it's a clinical as well as radiological diagnosis, but yes, we need to prove. And nowadays we are seeing this common history of tobacco smoking in, I'm very sorry to say, but women more than 20, routinely every third woman is giving history of tobacco smoking, either college going girls or working women, or even I have seen elderly women who has recently started smoking. They develop this idiopathic kind of granulomatous mastitis where they are getting repeated inflammatory lesions in the breast with sinus formation subsiding with antibiotic. Again, after 3-4 months, as tobacco exposure continues, it keeps coming and forming sinuses. So nowadays, that's why detailed history is very important in inflammatory lesions. Next slide, please. Yeah, nipple discharge. So again, I will not go into percentage. One, which is most important thing about nipple discharge, if it's unilateral, if it's non-spontaneous, single duct, blood-stained nipple discharge needs to be addressed. And cytology is not the right investigation of choice. If the woman is more than 40, presenting with nipple discharge, single duct, unilateral, blood stained, mammography, sonography needs to be done. If there is no lesion found in mammography or sonography, that duct needs to be excised and send it for frozen section, which is called as a microductectomy procedure. If there is a lesion within, which radiologist can tell you that the lesion, the duct is extending to the lesion, then along with microductectomy, you can take out the lesion and send it for, but always always it is advisable to do wide local excision, because what we are seeing as a, sitting in tertiary care center, when patient is referred for breast problem, mostly half-hearted surgeries are done. The lump is removed as a fibroadenoma, then margins are positive. The incision, type of incision is not taken properly. So whatever cosmesis we can offer as upfront surgery, we cannot offer in those patients. Or sometimes when there is no need for removal of nipple or single duct nipple discharge, patient comes with excision of nipple, just the local doctor has excised the nipple and send it for testing, and they didn't even mark the duct which was bleeding, so pathologist couldn't comment on what it is. So we completely miss out on diagnosis, and then we have to just assume that, okay, let's consider it's negative and we'll keep patient on close observation. So we miss out on opportunities to give chance of cure to patient if patient is not treated in a right hand and upfront. I mean, some excision is done outside, or some biopsy is done, wedge biopsy is done, and the tumor is left inside. Then again, we lose or miss out on the chance of cure at first presentation. Yeah, next slide. So again, etiology of nipple discharge, we will not go into it because everyone knows what are the causes. Management, we have discussed management of nipple discharge. And yes, so triple test is most important for all patients, and everyone knows about triple test. Is the first clinical examination, second radiological examination. Radiological examination does not mean mammography. I try to tell it every time in my talks, and whenever I get opportunity to share it on social media, radio, TV, that please tell your patients that mammography is not the only investigation which can rule out cancer, and negative mammography does not rule out cancer. This is the most important information we need to pass on to our patients, that how important is clinical examination and clinical index of suspicion. And let breast surgeon decide which investigation is right or which is a choice of investigation for your condition. Yes, again, biopsy, depending on the index of suspicion, whether it is needed or not. So BI-RADS is, again, everyone advise mammography. So everyone should know that when. So up to BI-RADS 3, we ask patient to observe because it is benign. When it comes to BI-RADS 4A, B, C, or BI-RADS 5 or BI-RADS 6, so BI-RADS 4A is a low index of suspicion, but we cannot, once radiologist writes BI-RADS 4A, we cannot keep patient on observation because there is a word mentioned, low index of suspicion. So you have to take that call when, depending on, you need to tell patient and talk to them that yes, this needs evaluation. So patient needs to see breast surgeon, and if it needs excision or biopsy to prove that it is negative or positive, depending on that, treatment will be given. But sometimes I have seen patients coming to clinic for BI-RADS 2 also. Someone has advised surgery, or they have done excision of the cyst, which is not required, or excision of tiny fibroadenomas, not required, unnecessary giving scar to patient, or removing lump as a fibroadenoma, coming it as a phylloides or cancer. Then again, treatment, giving the cosmesis or giving a chance of complete cure is again difficult. Yeah, next slide, please. Cyclical mastalgia, we are not going to. Yeah, so surgical excision for all symptomatic and rapidly growing fibroadenomas. Otherwise, all fibroadenomas can be observed. Next slide. Nipple discharge we have discussed that we can. So standard treatment for nipple discharge, single duct we have discussed, is a microdocectomy. And if the women is more than 50 and she has multiple nipple discharge and there is no underlying abnormality on sonography or mammography, then we do Hadfield's procedure where we excise the duct tissue, ductal disc, and send it for testing. And most of the time it happens that in that we get to know that whether there was a ductal carcinoma in situ or lobular carcinoma in situ, which was not picked on mammogram because it was non-calcified DCIS. Anything calcified, we can see calcific or microcalcification can be seen on mammography, but a non-calcific DCIS mammography cannot pick. So no one should ignore blood stain nipple discharge, which is unilateral and which is unilateral single duct or multiple duct blood stain and spontaneous. Yeah, again, so thanks to UNS for having all these wonderful products for our patients where we can use for cyclic nostalgia, and routinely we are using for all fibroadenomas which are less than 2 centimeter or fibroadenomas for which we are not doing surgery, or who those women who don't need surgery, we are they are showing excellent results with Primosa Boost, which routinely we are giving twice a day for 3 months, and after 3 months we are assessing. So all those tiny fibroadenomas, we are seeing that they are disappearing or going down into size. Yes, fibroadenomas more than 2 centimeter, more than 3 centimeter, they need excision eventually because they usually don't subside with medication. But whatever discomfort or pain associated with that is usually taken care with Primosa Boost. Can we have next slide? And again, we are not going to talk about all this, which has been covered. So if there are any questions related, definitely we can take questions and accordingly. Is it fine, Priya?
Yeah, it is fine, ma'am.
Yeah. So if there are any questions, I'm happy to answer.
Yeah, we'll see that we're evaluating from the event manager. For the time, let me thank you, ma'am. So thank you for your outstanding presentation. It was a privilege to gain insights into your clinical expertise and whatever you share and how you manage clinically the benign stress disorders. And where do you use the evening primrose oil in which category of patients? And as with the help of Dr. Amoya Kurunje, you noted that Primosa has been a legacy brand for over the 25 years in the market. So it's our privilege to have that Primosa as a UNS part, and our goal is to advance women's health through innovative approaches that minimize that give the efficacy to the patient and continue the success of UNS. Lastly, I would like to express my gratitude to AMOX and Dr. Kiran Kutagoti for giving us the opportunity to host this exceptional webinar with their invaluable support. Over to you, Priya, and I will check by the time if there is any question. Currently, I'm getting some event manager that there's no question from the audience. Priya, do you have any questions?
Yeah, I don't see any questions, but let me just confirm. 2 minutes, 2 minutes.
Yeah, sure.
No,
so
there are no questions. There are no
I was
questions.
having 1 to 2 questions before the webinar, but after hearing the Dr. Lucha and Dr.
Yeah.
And I think my doubts are clear.
So, Vikas, would you like to ask anything to doctors or share something? Or since there are no questions from the delegates, anything you would like to ask or share or discuss?
Vikas is more prepared and always prepared, and he is well versed with the topic always. So good that UNS has this medical team which is like very detailed and thorough. He is always in his thoughts.
Thank you, ma'am, for your kind words. Yeah, I was having 1 to 2 questions, but yeah, after hearing you, I think my doubts are solved. Like where you are using exactly evening primrose oil in the clinical practice. So you rightly mentioned that you are using when the lump size is very low.
Question whether UNS has this database where you can generate, because whatever data you will see, there is no robust data for use of primrose oil, like 200 patients,
5 मिनिटं
100
बसा
patients,
बसा जागा आहे ना
150.
इकडे बसा
Currently,
इकडे पण आहे
in
हा
nostalgia, the
5 मिनिटं
clinical data is
संपेल
widely
आता
there, but in
हे
benign
मी
breast
सोडू
cancer,
शकत नाही मध्ये
Priya, you can mute yourself. Yeah. So, in benign breast disorder, UNIS is trying to generate data with the help of one recognized institute. Currently, I can disclose it because it's under discussion. It can happen or it can't happen. But yeah, we are trying to generate more data with the help of in the benign breast disorder because nostalgia now recently 2 data more has come in 2024. But benign breast disorder, yeah, it's lacking nostalgia. But yeah, clinical experience when we talk to breast surgeons, yeah, they are getting wonderful results with it. That's we have. Like in AIMS, it is used widely. You are using that, and other lots of breast surgeons over India are using it. So we are trying to generate some case studies also with the help of breast surgeons in benign breast disorder, so it can be circulated as an Indian practice. So that can be helpful in the later stage. But currently, we are lack of strategic data at the clinical perspective in the benign breast disorder. In PMS and nostalgia, there are a lot of it. Anything else, Dr. Umar? From your side?
No. If any questions, we are happy. Otherwise, we can.
Yeah. So Priya, you can have a closing note or closing remark. Then we can end this session.
yes thank you so much. Am I audible, Vikas?
Yes.
Am I
Yes,
audible?
yes.
Okay,
Yes,
fine. So first and foremost, I would like to thank our biggest speakers, most reputed doctors from Mumbai across India. I would really like to thank from the bottom of my heart Dr. Amaya Purundare for really removing his precious time and really gracing this entire moment. Wonderful talk, sir. We got a lot of insights, a wonderful presentation, highly intellectual, interactive, and informative. Thank you so much. We would really look forward to, get more inspired and learn from you in future again. Thank you so much, sir. Next, I would like to thank Dr. Rucha Kaushik. I mean, although she is so educated, so knowledgeable, she is such a nice, down to earth person. And I'm so happy to know her and to learn so much from her. Ma'am, you are a wonderful speaker. I learned so much from your presentation. Highly inspiring and highly knowledgeable, and a wonderful person by heart as well. So I thank both the doctors for giving your time and come here. I thank Vikas Singh because he has really taken pains to make all, for the presentations and for the talks and the coordination, the medical information, for everything. So I thank you so much, medical department and Vikas, for helping us out. I thank the entire UNS sales team, the marketing team, because of them, they have organized this event. They have gone out. They have really, interacted with doctors. They have sent invitations and really, got the doctors here as delegates. So I thank the entire UNS sales team, the marketing team, and everybody. I also thank a lot AMOGs, okay, Dr. Kiran Kurkoti, who really helped us and gave us an opportunity to collaborate with AMOGs and, share and use their platform to network and market our webinar. Thank you so much, Dr. Kurkoti, and we look forward for more collaboration with AMOGs in future. Finally, I thank our technical team who assisted us for getting this entire webinar rolling out smoothly without any technical hassles or problem. Thank you all, and we really look forward to interact and meet and have such more sessions in future. Thank you so much.
Lastly, I want to thank my boss, Dr. Manish, and my medical colleague Shruti. So they have been guiding, helping me a lot in this, and giving me opportunity to do the webinar. So thank you, Dr. Manish. Yeah. Thank you, everyone.
Thank you.
Thank you.
Thank you so